started, I think. Okay. So, yeah, somebody's doing a little doodle on the screen.
Oh, okay. So what is that?
On the Zoom meeting. So we do have people that are online. We actually had over a full RSVP to attend online. I'm not sure if they're all going to actually show up or not, but we may have a lot of people joining us online. So we're really excited about that. And I'm Lyons Hardy. I work here at the School of Nursing as I coordinate the PsychNP program.
And I'm Olivia Reichenbacker, and I know Lyons and work as a nurse practitioner at an outpatient clinic nearby. So.
Okay, to get started, we neither of us has any disclosures for conflict of interest. We will be talking about off-label uses of medications. We have some great support for this talk. The School of Nursing provided the room. We have Sue McGinnis, who is our really wonderful IT person who's upstairs monitoring the Zoom meeting while we talk and recording it. We had Brack McPherson, who's one of my colleagues who helped us be able to provide CEs for the event. So we really appreciate that. And then Postpartum Support Virginia paid for the meals. Both of us did this on our own time. We feel very passionate about educating other providers on this topic and what led to our interest in this topic.
Yeah. So my interest primarily arose while I was just doing my nursing school career. In kind of my clinicals with OB, I just sort of became really interested in women's health in general. Too, and I'm still really passionate about women's mental health specifically across the lifespan, but where Lyons and I have focused a lot is on the perinatal reproductive period. So.
And for myself, my interest stemmed from my personal experience with depression during pregnancy and postpartum. I was really lucky to have some providers that worked with me that were really willing and comfortable to prescribe medications for me while I was pregnant and lactating, and it just led to me wanting to educate other people. I don't actually work with people in this population other than those that cross my path in my normal everyday PsychNP practice. But I'm really interested in educating other people because I've noticed that there's a lot of misinformation and incorrect information and just lack of knowledge in the field on this topic. So we're going to start out by just doing a quick interactive activity. If you can just turn to the person next to you or behind you, get in little groups of 2 or 3, and talk about some of your concerns or fears about prescribing medications to patients who are pregnant and or lactating. And we'll just spend about 3 minutes doing that and then kind of take some highlights from the group. And let me time it. I brought my little bell, which I love to use during my classes. Oh yeah.
That's hilarious.
And any kind of activity like this, I always get excited. Oh, I forgot to do the housekeeping.
Oh.
I was going to say bathrooms and questions. And I did say, okay, I did say some of this. I did say this and this and this. That's the only thing I think I missed. And questions at the end.
Yeah, that'll work. That's good. This is hilarious.
Yeah, it's great.
That's so funny. I wonder how long it's actually going to take us to run through.
Yeah.
I was thinking that last night. I was like, I don't think we have time for this. How long did it take us ISBN?
Well, we only had an hour.
I know, but it took us, what, like
I think 45? Like 45, and then we took questions, but we didn't do the case studies.
Right. So we added on probably 10 extra slides, you think, maybe a little bit more? They probably added on
probably more.
Another 45 minutes at least, or I don't know, maybe another 30 minutes. Let's find out. Where are we on the time?
4 seconds.
Oh, wow.
Okay.
Sweet. That was right on target. Cool.
Okay. My students know that I love my bell, and Catherine knows too. Okay, so let's hear a few highlights that came up in your conversations. Anyone want to share?
Be brave. Share your fears. Okay.
Everything? Okay.
Had a hand in the back too. Okay.
Mm-hmm. Just a lack of experience.
Mm-hmm.
What else? Yep. So you personally didn't feel comfortable, so that leads you to feel less comfortable as a prescriber. Okay. Mm-hmm.
Concern about long-term effects of the child.
Okay, so concern on the fetus or the baby once it's born, or the child. Mm-hmm.
Yeah. Yeah, in the back there? Nope.
Yep.
I'm not a prescriber, but as a lactation consultant,
Mm-hmm.
my concern was always that they wouldn't prescribe,
Mm-hmm.
even though there was literature to support
Mhm.
that depression in a mother was detrimental to an newborn. And so
Yeah.
Yeah.
I was always,
Mhm. Mhm.
So I think I had the reverse perspective of, okay, now there's literature,
Yeah.
let the patient
Yeah.
know the information, the risk versus benefit.
Gotcha. Yep.
I've been a prescriber for a lot of years, and I've seen that go, the pendulum keeps going back and forth.
Mhm.
First it was keep them hospice, started before they deliver, and then it was keep them on and take them off
Mhm.
before they deliver, and then it keeps going back and forth.
Mhm.
Like, you look at the sort of, and like if I were to get sued from the baby that's not going to go for 5 years or
Mhm.
whatever, well, it depends on what is that at that period.
Yeah.
And I was
Right.
prescribing
Mhm.
what I was supposed to do. And
Right.
it was a long-term. So,
Mhm.
and, well, I've done it back and forth all these different ways. I've never heard of any of that. So I'm going to do what works, which is to, if it's working and you're on it, stay on it.
Mhm.
Yeah.
That's a very small risk.
Mhm.
And like this one, especially, studies show that if mom is depressed, she's going to be.
Mhm.
Why? With this small risk of having a baby, unborn child, are you going to distrust it?
I think that's a
End up being depressed. Doing that.
Yeah, I think that's a really interesting concern. I don't think we've heard that a lot about just like the back and forth
Mhm,
shifting of
mhm.
the recommendations over time. So
Mhm. So hard to keep track
it
of
is.
it.
It's hard to keep
Mhm.
track.
Mhm. Great.
Okay.
Thank you all for sharing those. I forgot to mention 2 housekeeping things. One is the bathrooms are right across the hall, and there's a water fountain out there also if you didn't know where those were. And the other one is to ask everyone to hold your questions till the end. We do have a large group, and we have a large group online too. So if you have a question during the presentation, just jot it down, and we will have time for questions at the end. All right, so let's move on.
Okay, so this presentation is going to focus primarily on the medication management.
I'm sorry can I just stop you for just 1 second?
Yeah.
Yep.
If you guys don't mind, if you do take a comment or question from the audience, if you can just repeat back, because I muted the microphones for the audience and the remote participants are eager to hear their comments. Thank you.
Yes,
Okay, sure.
thanks.
So non-pharmacological interventions, there's tons of them, therapy included, and we definitely recommend those, but we just don't have time in this short window to talk about all of that. ECT, there's pretty good literature to support the use of ECT in pregnant patients. Again, not going to discuss that in detail. We, I think, both get a lot of questions about THC use during pregnancy, but there's just very little data on this. But it's a pretty common practice for people using it, especially for nausea and anxiety and things like that. So,
and that applies to all socioeconomic statuses. It's becoming a lot more commonly used during pregnancy, and there's a perception that it's safe to use during pregnancy. So that's definitely something to assess for and to educate patients about. So I want to make a little note about inclusive language, that we're both trying to move our language to using certain terminology. One of those is to use lactation instead of breastfeeding, since there are patients who will be lactating and maybe exclusively pumping, but may not be breastfeeding or nursing. So I'm trying to move everything into talking about lactation versus nursing or breastfeeding. You may notice a couple of errors sometimes because it can be hard to adapt language patterns that we're used to. And then the other one is related to gender inclusivity. So we do have patients who are carrying pregnancies now who do not identify as women or as female. So we're trying to use the word patients or people to describe instead of moms or women when we're talking about people who can become pregnant. I do think there are a couple errors still in this talk, even though I've gone through it several times trying to correct them. So you may notice that, but try to catch myself when I notice myself doing it.
I definitely probably will still use the term women a lot just because I'm thinking about my own clients, but we are definitely all trying to move towards more gender inclusive terminology.
All right, so to get started, we're gonna give an overview of some of the types of treatment that we may be providing to people who are in the perinatal period, which perinatal period we'll talk later, but it does apply to conception through a year after delivery. So you may have patients who had a pre-existing mental illness and then became pregnant. It can be destabilizing for them in terms of their psychiatric symptoms, and there may be safety concerns or issues. Sometimes hospitalization may be required. So in this case, I'm kind of thinking of patients that have a serious mental illness who become pregnant, and that experience can be destabilizing for them. Then we also have people who develop a new onset or recurrence of mental illness during pregnancy or postpartum, and this can be a range across the spectrum of different types of disorders that can present.
Yes, so as Lyons mentioned, we are talking about a perinatal period, so the entire pregnancy through the first year postpartum. Different specialties think of the perinatal period differently, but for mental health purposes and for the purposes of studying the perinatal mental health period, we are looking at that time frame. It's also important to note that, most of our clients think about postpartum depression, and that's in fact a lot of the way that even still a lot of providers in the medical field think about it. But it's really across the spectrum. We see mental illness antepartum as well as postpartum. We see all types of mental illness occur. Some examples are depression, anxiety, panic, OCD, PTSD, bipolar disorder, psychosis, and substance abuse, which are the main ones we're going to focus on. But any mental health concern that can happen at other times can also happen during this period. It wasn't that long ago that really the common medical knowledge was that pregnancy was a protective time and postpartum period was a protective time against mental health concerns. People perceived this as a time of joy, contentment, whatever it was. And honestly, it wasn't until research in the 80s that we really actually showed through studies and research that that was not the case. And for some conditions, it's actually a time of higher risk. So why should we care? So some of the consequences, there are a lot of different consequences for both mom and baby for untreated mental illness during the perinatal period. So there can be developmental delays and behavioral problems in the offspring, discontinuation of lactation, increased costs of healthcare, and then infanticide, homicide, and suicide. And an important note is that suicide methods during the perinatal period are more likely to be more lethal. So think we're familiar with the fact that in general, maybe where women will attempt suicide more, their methods tend to be less lethal. That's not the case for this time frame. So suicidal ideation and things of that nature are maybe more pressing. Some social considerations and consequences would be child neglect and abuse, relationship problems and divorce, and then disability and unemployment. So a lot of the people who are here today are psychiatric providers, but not everybody. So we don't expect that every person is going to be able to identify exactly which disorder the patient might be presenting with. So some of the common symptoms that we might see that might alert you to the fact that something is wrong, whether you know exactly what it is or not, are anxiety, insomnia, irritability, and physical complaints. We see that across the spectrum for a lot of different mental health concerns or disorders. Anxiety in particular is often a key feature. It's a lot of times what people will present with. Even if depression might be, more serious for them, anxiety is kind of what they come in talking about. Insomnia, this can be a really difficult one to differentiate because there's obviously a lot of really intense changes in the sleep cycle in the postpartum period, especially when you have a brand new baby. Parents are often up all night or up frequently throughout the night, but the key is distinguishing this is that the parent isn't sleeping when the baby is sleeping. And that might be for a number of reasons. Perhaps they're expressing that they have increased energy and they don't feel like they need to sleep. Maybe they tell you that they're having a lot of anxious thoughts, their mind is racing, they just feel very restless. Those kinds of things would alert you that there's a problem. Irritability is also an extremely common symptom. And again, sometimes that can be pretty normal in the postpartum period, especially with people getting less sleep and things of that nature. But when it's a little bit excessive or above and beyond the normal range, we're worried. Physical complaints are really common, especially in relationship to anxiety. So physical complaints that we can't identify a medical cause for, we should be thinking if there's perhaps a psychiatric cause.
Okay, so just to cover a little bit with epidemiology, I'm not sure if I don't think I defined, or I don't remember if we defined PMAD, but perinatal mood and anxiety disorders, and it pretty much applies to any psychiatric disorder, but that's kind of the term that's used a lot, PMADs. So having depression and or anxiety during pregnancy, up to 20% of people may experience that. And actually 60% of cases of postpartum depression actually did have an onset during pregnancy, but it may not have been recognized or reported at that time. So in terms of depression, most people may be aware that there's a lot of hormonal fluctuations that occur after delivery, and there's what's considered to be relatively normal experience of baby blues that affects 50 to 85% of people after they deliver, and usually remits within 2 weeks or so after delivery. They retain a good outlook with positive bonding, and the tearfulness and reactivity may peak for about 3 to 5 days and then starts to decline, and they return back to their baseline. And when we're looking at more of a diagnosable condition of postpartum depression or anxiety, it's actually about 10 to 15% of patients, so that's quite a few. Usually develops within the first 2 to 3 months, but it can really be any time after delivery in that first year to be considered postpartum depression. So typically there'll be a depressed mood or feelings of sadness, loss of interest or anhedonia, and an impaired bonding between the infant and the parent. And then you also may see, as we talked about, some of the other symptoms, irritability, insomnia, or possibly hypersomnia, changes in appetite, suicidal thoughts, all of these typical symptoms that you might expect to see in a major depressive episode. And then for anxiety disorders and panic disorders, about 15% of people will have some type of perinatal anxiety, and the symptoms can range from agitation, being restless, worrying a lot, having racing thoughts, and into full-on panic attacks. So Olivia talked a little bit about the physical complaints that can present at this time. Panic attacks would be episodes of severe extreme anxiety that include a physical component typically, so chest pain, sweating, shaking, dizziness, heart palpitations, that sort of thing. I think we start to differentiate when it becomes an abnormal presentation, when it's really interfering with the person's ability to function in their daily life, to take care of the infant, to do what they need to do. There may be some normal worries associated with being a new parent, So this would be kind of a extreme version of that. And then postpartum obsessive compulsive disorder. So this is also, I would say, a fairly high incidence, 3 to 5%, and 11% of postpartum women, which is often comorbid with depression. So women who are in the perinatal period, patients who are in the perinatal period, have 1.5 to 2 times greater risk of developing OCD than the general population. A really, really common presentation here is intrusive thoughts. So it's often related to harming the baby in some way. So the parent may start having intrusive thoughts that they are going to harm the baby, or that the baby is going to be harmed in some other way. And that can be very disturbing and troublesome to them. And there can be a lot of shame associated with it. So you shouldn't expect them to disclose this to you automatically. You have to assess specifically for it, because a lot of times people are embarrassed that they're even having those thoughts, or they're very confusing to them. Why are they thinking those things? Does not mean that they're going to act on them. Typically, these are ego dystonic, which would mean that they don't want to do them, or they're hoping that they're not actually true. So it doesn't mean that they need to be hospitalized right away if they're having some of these thoughts. You can also assess safety in other ways to determine whether they're safe to be at home with the infant. And can you talk about this campaign? Because I'm not as familiar with that one.
So Massachusetts General Hospital is kind of one of the leaders in the country for perinatal and reproductive psychiatry. And they, I feel like several years ago, developed this campaign called Ask Her, just basically to get people to start asking moms about their intrusive thoughts, because it is such a symptom associated with shame for people who are experiencing them. And this was also kind of geared towards educating providers who might be asking these questions that, again, these thoughts don't equal action. So we don't necessarily need to separate the parent and the child, or place the parents in involuntary hospitalization or things of that nature, just because they are having these thoughts, because they're very scary to them. Like Lyons said, ego dystonic, they do not want to act on them typically.
And one way that it can be good to assess for these is to provide some normalization. So to say something like, some people experience these thoughts that they feel like they can't control, and they could be something really disturbing, and give an example. And then, has that ever happened to you? So that they don't feel like they're alone or the only person that's ever experienced it.
Post-traumatic stress disorder is another very common psychiatric condition in the perinatal period. A lot of patients come to the perinatal period with histories of trauma, but the perinatal period can also present new traumas. So about 12% of the pregnant patients and 9% of postpartum patients have PTSD symptoms. And if you're not familiar with PTSD, symptoms are pretty commonly re-experiencing, so having like flashbacks of the trauma, hyperarousal, like hypervigilance or always being on the lookout, nightmares, avoiding triggers, isolating yourself, and a very sometimes distorted sense of blame. 34% of moms patients experience a traumatic birth. So traumatic births can involve a lot of different things. Sometimes things that we as providers or healthcare people familiar with the healthcare field seem to think are pretty routine. So cesarean births, forceps or vacuum extractions, or even lacerations, all of which I think are probably within the normal range for most people working in those fields, can be very traumatic for patients. Obviously, things like postpartum hemorrhage, premature birth, a baby that has to go to the NICU, and things of that nature that are more extreme can be very troubling. A lot of times we as providers sort of have this perspective like the ends justify the means. If the patient and the baby are healthy, then maybe all of this trauma and the horrific things that might have happened during the birth are worth it. But patients often don't feel that way. So it can lead to an avoidance of aftercare, impaired bonding, sexual dysfunction, and future elective cesarean sections, even when they're not medically necessary. Survivors of abuse are at risk of being re-traumatized. Perinatal care is extremely invasive. We definitely need to have a sense about us if we're working with perinatal patients that there is a body memory of abuse, and you need to alert the person before you're touching their body. So telling them what you're about to do can be helpful to not further that trauma. Sometimes the re-traumatization can lead to episodes of dissociation and, again, lactation problems. Bipolar disorder, very, very common and very commonly misdiagnosed as well as unipolar depression. So 21 to 54% of the patients who present with postpartum depression actually have bipolar disorder. 50% have their first diagnosis of bipolar disorder during the perinatal period. And 71% with an established diagnosis had a reoccurrence during pregnancy. In fact, up to like half of the patients who were stable had a relapse or exacerbation of their symptoms during pregnancy. More often than not, we're seeing these postpartum or bipolar disorder cases presenting with mixed or depressed episodes in the postpartum period. 70% will relapse within the first 6 months after birth, even if they've previously been stabilized on medication. When we're looking at differentiating bipolar depression from unipolar depression, a helpful mnemonic is whiplash. We're looking at if a person is experiencing worsening of their symptoms or they seem more wired on antidepressants, if they have a history of hypomania, even if that's not necessarily a full manic episode. Irritability, psychomotor retardation, so being very flat, not moving as much, that kind of thing. Strong family history, an abrupt onset or ending of the depressive symptoms, and if they do have a seasonal or postpartum presentation. Postpartum psychosis fits really well in with bipolar disorder because 86% of the people who experience postpartum psychosis have bipolar disorder. It's still very rare, 1 to 2 per 1,000 develop postpartum psychosis, but these are the people who are typically at higher risk of hurting themselves or others. So 5% commit suicide and 4% commit infanticide. Again, obviously not the full spectrum of people who experience postpartum psychosis, but these are the people that we are a little bit more concerned about safety for. 50% of patients who experience postpartum psychosis have no previous psychiatric hospitalizations. So they may have previous psychiatric illness, but these are not necessarily patients that we're already on the alert for as having had serious mental illness in the past. Onset is typically within the first 3 weeks, and actually I think more recent research has said that it's oftentimes within the first 72 hours, but it can occur at any point in the postpartum period. Symptoms are pretty standard for any psychotic episode: delusions, hallucinations, confusion and disorientation, and one that's kind of confusing, especially for family members who are seeing this, is the waxing and waning of symptoms. It's not always the case that the person presents with these symptoms consistent throughout the day. Sometimes even within a day, the symptoms can worsen or lessen. Again, these people may be at risk of harming themselves or the baby, especially with command hallucinations. Oftentimes the thoughts of harming the baby or themselves are egosystonic. So the mother feels that they're reasonable, or the patient feels like compelled to act or tempted to act on them. Again, especially with command hallucinations in which the patient is being told to do something. Up to half of patients can have an isolated postpartum psychosis episode. The mechanism of onset, we're still definitely getting a feel for this, but it seems to be related to the psychological changes or physiological changes after birth, So hormonal changes in the circadian rhythm, and immune changes as well. Autoimmune thyroiditis, infections, or NMDA encephalitis might also be somehow related. We really don't quite fully understand the origins of postpartum psychosis, but these are definitely possibilities. Because so many patients who have postpartum psychosis do have bipolar disorder, lithium is typically the first line and also considered good prophylaxis in patients who have a history of postpartum psychosis.
Yeah, so normally if someone has a history and then they have a subsequent pregnancy, they would be started on lithium as soon as possible after delivery in order to prevent postpartum psychosis. And that's assuming they did not need medication during their pregnancy.
Right.
Substance use disorders are also another big consideration with pregnancy. And so some of the data that I found were from 2012, and you can see the numbers up there. The highest rate is definitely cigarette use for substance use during pregnancy. The polysubstance use, that does not mean it's 50% of pregnant women. It means when people who are abusing some type of substance, at least 50% of them are abusing multiple substances. There's also higher rates of opioid abuse like we're seeing in all populations. There's a lot of comorbidity with other psychiatric illnesses, and the substance use disorders are associated with a lot of negative outcomes for both the parent and the fetus and future baby. There's a lot of specific recommendations for managing substance use disorders during pregnancy that I don't think either one of us are super familiar with those, but they are out there. There's different medications that are used to manage the disorders if the person is able to stop abusing the substance. Oh, we got another red line. Wonderful.
Oh, no.
Okay. So some of the risks that you might be looking for perinatal mental illness, risk factors. So prior mental health problems, family history of mental health problems, trauma, like we talked about, having a traumatic birth or a history of abuse, history of psychiatric complaints related to other hormonal changes. So if the person has history of severe PMS or premenstrual dysphoric disorder, then they may be more likely to experience something during the perinatal period. But it is also important to remember that many people experience their first episode during the perinatal period, so they may not have any history at all and no obvious risk factors. All right.
So when we're talking...
You want to take questions up to this point first before we switch into medications?
Yeah.
Any questions about what we've talked about so far? All right. So we'll switch into medication, talking about that more specifically.
Okay. So when we're thinking about using medications during the perinatal period, basically the golden rule is that we want to eliminate one exposure. So we're always weighing the risk of the untreated mental illness versus the risk of the exposure to the medication. Okay. So there's no such thing as zero risk. We have to always be considering both of these potential exposures and eliminate one. So that means if we do decide to use medication, we need to use medication to its most efficacious, I don't know what I'm saying right now.
Place.
Right. We need to use it as effectively as possible. Okay. So there's a lot of research that indicates, and one study in particular that really showed that a lot of women, patients receiving care and treatment with medications during the perinatal period were still symptomatic because they were receiving suboptimal treatment. I think there's a strong culture in the field of medicine that if we're going to prescribe medication to a perinatal patient, that we try to use the lowest doses possible. But then we're really just exposing the baby to two exposures, right? We're exposing them to the medication and we're exposing them to the untreated mental illness in the mother. Because if we're only using those suboptimal doses and they're not getting the full symptom control, we have both exposures. This study showed that the mean dose of Prozac was 23 milligrams and the mean dose of Zoloft was 68 milligrams. As many of you all who prescribe these medications frequently know, those are basically the starting doses of these medicines. Sorry, we're going to take a little second.
Yeah, just a second. I'm sorry. So folks on the other side, please don't use the annotation tools. I'm interrupting the lecture so that I can actually go ahead and disable the annotation tools because it's sort of ruining the whole vibe here. So sorry, and then let's see if I can actually go ahead and clear all drawing. Thank you. Yeah,
oh, okay.
I couldn't do it from my view. I apologize, and let me go ahead and close this as well.
That's okay. Thank you.
Fine.
We appreciate it.
Okay. We don't have our red lines anymore. That's all right. We'll live without them. Okay, yeah, so basically these are very low doses. For some patients, that might be all they need. You shouldn't just push somebody up, obviously, just assuming they're going to need higher doses. But I would say more often than not, especially when we're treating anxiety and things like that, higher doses are typically required. So. Okay, so again, that risk-benefit analysis, there are no absolutes. Every client is going to be an individual case that you have to determine with the client whether or not the medication is appropriate for them during the perinatal period. So we went over a little bit in that previous slide, like the why should we care, some of the consequences of untreated mental illness, but there are some others too. Substance abuse, low birth weight, poor fetal growth, preterm delivery, pregnancy complications, and depression during adolescence and the offspring. Risk of major malformations is typically the thing that especially patients are most concerned with, but a lot of providers are most concerned with. It's also where most of our research is focused, is on whether or not medications increase the risk for major malformations. But when we think about this risk, it's really important for us to think about the fact that there is a 2 to 4% baseline risk, and 3 to 5, depending on the research that you look at, risk of major malformations in the general population. So a healthy pregnancy will carry this risk regardless of any other exposures. Most of the psychiatric medications, even the ones that have an established teratogenicity, only carry an absolute risk of 1 to 2% or less. That doesn't minimize that risk, right? We're not minimizing whether that risk is scary to the mom or scary to us as providers, but it's important to remember, especially in cases of patients who have serious mental illness where we might be our only option or the best options are medications that do have this history. For instance, lithium has a history of that. So some of the long-term effects, I think you had mentioned that was one of your concerns. Unfortunately, we don't have a lot of research. We don't know a lot about whether or not exposure to these medications causes long-term neurobehavioral issues or other perhaps brain-type structure effects in children. We are doing more of that research now, and I think that there was some new research at the end of April actually that looked a little bit at that to start with, but hasn't come up with anything conclusive yet. So
there was a study that came out recently that followed, I think it was a cohort of about 50 to 60 children up to like age 12. Sorry, yeah. I'm not remembering the exact details, but it showed positive effects on the children who had prenatal exposure to antidepressants. So that was a good finding.
Another couple of different types of risks, persistent pulmonary hypertension in the newborn. That was something that I think a lot of providers were concerned with, in the last 5 or 10 years, but approximately 5 to 7 years ago, the FDA revised its warnings on this because there really hasn't been a lot of research to support that there actually is an increased risk for PPHN in babies who are exposed to SSRIs in particular in the perinatal period. So if there's a risk, it's very small, and other variables, in the best research that we have, other variables were actually associated more with increased risk for PPHN than SSRI exposure, like maternal diabetes, obesity, cesarean delivery, and some other ones. Transient neonatal distress syndrome, or another term is poor neonatal adaptation syndrome. This is associated with SSRIs and benzodiazepines. There is pretty consistent evidence that 25 to 30% of infants exposed in the late pregnancy period will have this transient distress syndrome. I don't think that we can say for certain what the mechanism of action is precisely. Excuse me, sorry. But the bottom line is that it's a pretty transient condition. So the symptoms typically last less than 48 hours. They include things like jitteriness, restlessness, increased muscle tone, and rapid breathing. Sometimes babies are brought to the nursery or the NICU because of, especially sometimes with the breathing issues, but there's no medical interventions that are specifically necessary. Typically it just resolves spontaneously.
Something important to keep in mind related to research on these kind of things is that a lot of the research studies are kind of poor quality and they don't control for other factors. So they don't always control for maternal depression, or they may not control for some of these other medical conditions. And so it's really difficult to determine if it's actually the medication that caused something or if it was another factor that was associated.
Another consideration is that even when people are stable on a certain medication, sometimes we do need to increase doses as pregnancy progresses. There are a lot of physical changes, big fluid volume changes, and a lot of hormonal impacts on the way that the body metabolizes the medication. So even for stable patients, we're going to monitor them pretty closely throughout the entire pregnancy and postpartum period. I would say at least every trimester, and then especially after delivery as well.
Okay, so I want to go over kind of some questions that you can ask yourself when you're trying to create a thought process for how to select actual medications to use during pregnancy. And we will be talking more about specific medications as well. But this is sort of what I came up with out of my own thought process and wrote it down in a form of questions to share with my students, and then started sharing it when I presented on this topic too. So some of the questions you're going to want to ask yourself What is the condition being treated? That's a pretty basic one. So if they don't have an accurate diagnosis and you're not a psychiatric provider, they may need to go see a psychiatric provider to get an accurate diagnosis on what's going on. How severe are the symptoms? So is this something that we need to intervene right away, rapidly, or is it something that they could try therapy first before they do medication? So that's something else to look at. And then when you're looking at actual specific medications, first question to ask yourself is what has worked for them in the past. So we see a lot of people going, well, if they're pregnant, they have to be on Zoloft, when, that's maybe not the best choice for that patient based on what they've tried in the past and what's worked for them. And that's not actually accurate. So getting a good medication history is important. If they're already on a medication, typically it's better to keep them on that medication than to try to switch them to something else during pregnancy. So then we're going to look at what kind of research and information is available on the medications that may treat the disorder that they have. And we're going to give you all some resources that we use and that you can use to look up medications and find out kind of what's out there. And along with that, looking at what has the most research data during pregnancy. Sometimes you're lucky and you can use one of those medications that we have a lot of evidence on. Other times that's not an option. And so we have to kind of do the best we can with the information that we have. So we also want to try to reduce medication burden if possible. I always try to do this in all patients, but particularly in pregnant patients as well. Can we use one medication to treat multiple symptom clusters so we can avoid multiple medications or polypharmacy? Are they already on any other medications for other conditions? And how many weeks gestation is the pregnancy is a really important question to ask too, because it's very different, if someone just found out they're 6 weeks pregnant or they're 35 weeks pregnant, where you're looking in terms of medication selection and how where the fetus is in terms of development. Do they have access to high-risk pregnancy monitoring, NICU services? Those would be important considerations as well. Does the fetus have other risk factors? Is the parent smoking or using substances or other things? And thinking about if they would like to breastfeed or try to breastfeed, that may inform your medication decision-making as well when you're picking something during pregnancy. So I'm going to talk a little bit about the FDA labeling. Does anyone still using categories A, B, C, and X? I hope not. So that has been replaced. It's no longer in use. If you hear people talk about that, you can nicely correct them. We do not use those categories anymore. They were based on animal studies and any available human data related to teratogenicity. So they really provided some inaccurate information because sometimes it just meant that there was no study showing anything bad happening in mice. And that meant that it was a category B, basically, even though we didn't know anything about its use in humans. So they were pretty uninformative. So we're not using those anymore. If you can just Google FDA pregnancy category labeling, and you can get to the new labeling changes. And they released I forgot what they call them, but a little informational thing about that. So the way that it works now is that the labeling is in the package inserts for the medications, which you can also easily get by Googling. And it'll include information about the known effects during pregnancy, lactation, and females and males of reproductive potential. So that can be important for some medications as well.
So there still floats around, just like these pregnancy category labeling, a lot of myths and misconceptions. One of the major misconceptions was that weaning the medication right near birth would either prevent or reduce the incidence of any postpartum issues with the fetus, such as the transient neonatal distress syndrome. There is zero evidence base for the benefit of that, and they've studied it specifically, the transient neonatal distress syndrome, and found that weaning it near birth does not affect whether or not the baby will experience that syndrome. Changing medications for breastfeeding safety. There are some exceptions to this, but generally not recommended. The levels transferred to the baby in lactation are typically much lower than those transferred in utero. So when we're thinking about changing medications specifically for the lactation safety, we have to really weigh whether or not that is beneficial as compared to the risk of destabilizing the patient.
Is this me?
Oh, I don't know. Let me see. Sorry. Where are we? Yes. So we're also talking now about the evidence-based practice. So because this is a field that is constantly evolving, something that, you know, we heard here in the room today about concerns about how it's kind of always shifting, we really have to stay up to date. And that means using the evidence appropriately. There are always new studies, new research coming out. So we have to consider the quality of the study and how it was conducted. Ideally, we would have studies that compared women who have both or have the psychiatric illness and those that don't, and give them both medication, but that's unethical. And pregnant patients are still considered a protected group as well, which makes ideal research more complicated. Limitations are many of the studies that we have are based on registries or the retrospective analyses. Some of the studies only look at the pharmacy records, which that seems...
It doesn't indicate, obviously, whether the
because
person was taking the
we don't know
medication.
if they're just filling
just
it,
whether
not
they're
taking
filling it.
Right. So studies don't really, a lot of the studies that we have, in fact, most of them don't control for the severity of symptoms, maternal mental illness, substance abuse, prenatal care, a lot of confounders that we know are associated with poorer outcomes. The most optimal research that we really currently have available to us is prospective research that controls for the confounders. Again, literature is constantly evolving. We just have to stay up to date. The website that Lyons and I both use frequently is womensmentalhealth.org. It's not the only resource, but it's a good resource, especially when you're looking for updated literature and good syntheses of the literature. They do a good job of explaining what we're supposed to take away from the literature and analyzing the quality of the study that was conducted as well.
All right, questions about what we've talked about so far before we get into some specific medications? Okay, you all are a very quiet, compliant audience. Thank you. All right, so we're going to talk about some specifics in terms of selection of medications. And these are very general overview type of information. You will probably run into situations where one of the medications the patient is on is not on the list of the most commonly used or most evidence. So then you're gonna have to dig in a little bit deeper to try to find out if that medication is safe. But as we mentioned, levels may change during pregnancy, so you may need to increase the dose as the pregnancy progresses, and that would just be based on symptom presentation and symptom control. So you don't automatically increase the dose, but you monitor how the patient is doing. So in terms of antidepressants, most people probably are aware that fluoxetine and sertraline or Prozac and Zoloft have the most data. Typically, sertraline would be the drug of choice, especially for people who plan on breastfeeding. Generally, other SSRIs and SNRIs are considered safe. We do have some newer antidepressants out there like Vibrate or Trintellix or even Pristiq that don't really have a whole lot of evidence. So those I would recommend staying away from if possible. But it's possible to use them if that is the only choice that you're left with. There was one study that showed an increased risk for ADHD in children who were exposed to Wellbutrin in utero. Wellbutrin is a different mechanism of action than SSRIs and SNRIs, so we don't know if there might be some differences there. That was only one study. It has not been replicated.
I don't think that they controlled for ADHD in the apparent either. So.
There we go. As you see, the studies are not always high quality. There was a lot of sort of like bad thoughts about Paxil, and Paxil should never be used because of the risk of PPHN. But the data were reanalyzed from those studies, and it did not show an increased risk. Oh, and then also there was a cardiac defect, I guess, risk that was thought with Paxil as well, but that was not replicated when they reanalyzed the data. I'll say that there are a few people who publish a lot in this field who may seem to have some biases in their publications. And so a lot of the studies that you'll see reported in the media have been from a particular group that seems to analyze their data in a certain way. And when the data are reanalyzed by other groups, they find different findings. So just something else to be aware of. Mirtazapine or Remeron is something that has been used for people that have a comorbid hyperemesis and depression. It does have an effect on nausea and vomiting as well. So there's multiple case reports on that. So that might be a potential option for someone that has that comorbidity. And then moving into mood stabilizers. So our favorite one to use is definitely going to be lamotrigine if possible, if that's something that works well for the patient. It seems to have the least risk of any kind of complications during pregnancy. There are some recommendations to supplement with extra folic acid if someone is on this. That's somewhat mixed. There's not a strong opinion on that, but often you'll see recommendations of 4 to 5 milligrams a day of folic acid. And again, the levels may decrease during later pregnancy. This medication is definitely passed in breast milk, but there have not been any adverse effects shown. So something to keep in mind, it's not an absolute no. It might be best to avoid it if possible, but it's okay if that's the one that works the best for that patient. Valproate or Depakote is known to be teratogenic. That's an avoid if at all possible. I really don't prescribe that at all to any patients who have the potential for pregnancy. I just think it's too risky. And I think some of the European countries have come out with guidelines saying that it should not be prescribed to people with the potential for pregnancy. And it's pretty rare that that's the only medication that someone can use. It's possible, but it's pretty rare. Carbamazepine or Tegretol is another possible option that could be used. And you may find more in the neurology literature related to anticonvulsants during pregnancy because they have to use them. I mean, they have to be able to treat seizure disorders during pregnancy, and it's sort of viewed maybe a little bit differently than bipolar disorder because of stigma. So I've found more studies that are in neurology journals on these particular medications.
So just really quickly, a note on Lamictal as well. I think the primary concern for a lot of people who know that the Lamictal is passed in the breast milk is about that risk for Stevens-Johnson syndrome. There's actually never been a case that has been attributed to Lamictal in the offspring. So, not a case that's been attributed. There's not actually ever been an established case of this that's happened in the offspring of a person who has been breastfeeding while on Lamictal. So that's something important to remember.
But I would want to educate someone,
definitely.
especially if you were starting it new when they were lactating, because if they're on it during pregnancy, then the fetus was already exposed to it and theoretically would be kind of continuing their exposure if you're starting it new.
Yeah, absolutely. I definitely educate that even though there's never been a previous case of it, that there's still a risk of it, a theoretical risk.
So who here thinks that they should never prescribe lithium during pregnancy? Anyone?
Why?
Don't be embarrassed, because a lot of people say that, and that is actually not accurate. We can prescribe lithium during pregnancy, but for some reason it became this thing that was taught that you should never, ever prescribe lithium during pregnancy. Yeah. So it does.
Can Coulter,
someone needs to mute their line who's online. Okay, so lithium does have a slightly higher risk of Epstein's anomaly, thank you, which is a cardiac malformation in the fetus. But actually, let me make sure I'm saying the numbers right. Okay, so it's a 1 in 1,000 risk versus a 1 in 20,000 baseline risk. So it does elevate the risk over baseline, but it's still not a high absolute risk. Ideally, if it could be avoided during days 18 to 55 of pregnancy during fetal cardiac formation, that would be best. That may not always be possible depending on the severity of the illness. So it's recommended to increase fetal monitoring and collaborate with high-risk OB so that they can get some extra ultrasound and possibly a fetal echo if necessary. Again, levels of lithium are very sensitive to fluid volume changes, but we do recommend treating the patient's symptoms and not just automatically increasing it to get to a level. If they're okay and their level's decreasing, but they're stable, that's fine. Some people will do divided doses near the end of pregnancy. I'm not even sure why that is. Is that to keep the level more stable or something?
To the expected fluid volume shifts at birth, but I don't know exactly.
Okay. And lithium during lactation, again, that was usually in the past was like an absolute not, can never do this because lithium is definitely passed in breast milk, but it's being done a little bit more commonly now. And it also used to be thought that the infant had to be have their lithium levels checked, and that's kind of not as frequently done as much either. That's a pretty new thing, I'd say, within the past like 2 years, that people have been more comfortable using lithium during lactation. You may see some recommendations for holding the lithium during labor and delivery and resuming after birth, but we don't really have much evidence on that. So it's not something that would be strongly recommended.
All right, so antipsychotics. There's actually a pretty good amount of data on second generation antipsychotics showing safety actually during pregnancy and lactation. So we do have a preference for older agents that have more data. Currently, the agents that have the most data are, I think in order, Seroquel, Abilify, Risperdal, Zyprexa, and Geodon. Really the only one of those that's ever showed any potential for perhaps increased risk for malformations would be Risperdal. There was research that was done not that long ago, actually, that found potentially an increased risk for cardiac malformations. But the caveat is that we really don't know how to interpret that data as far as what we're controlling for other things and things of that nature, and not really sure what the actual mechanism of action would be, why that medication might affect cardiac formation when others that are very similar in action do not. So keep that in mind, potential risk, but not necessarily established by any means. If you're looking for a first generation antipsychotic, Haldol is most commonly used, and that's got a very good amount of data as well. Avoid the Latuda trap. So there is.
So who has heard that Latuda is safe during pregnancy? Latuda is category B. You should use Latuda during pregnancy.
Yeah, so that's not true. It used to be category B before we ditched those categories. But really, we have zero human data on this, even as of, like, I checked the MGH website yesterday to check on this to see if we were going to talk about this. And they have more people in their study currently enrolled who are on Latuda. So hopefully sometime soon we'll have data on it, but we don't yet. So even though it did have that category B rating that was not based on human studies and not based on really the evidence that we consider essential in order to feel as comfortable as possible prescribing to patients in the perinatal period.
And it was one that the drug company really picked up on, hey, we're going to promote this heavily because it's a category B. And so that's where I think a lot of that misconception came from.
Yeah, absolutely. So some of the anxiety and insomnia as needed medications, benzodiazepines can be used sparingly during pregnancy, ideally avoiding routine use because there can be there can be tolerance and sometimes potentially withdrawal in the baby after birth. I don't think that we have a lot of evidence that withdrawal is something that's significant, but there are some folks who suspect that that's what's happening with the transient neonatal distress syndrome in babies who are exposed to benzos on a regular basis in utero. Hydroxyzine and diphenhydramine are very similar. There's a lot of data actually, I think, on both, but ideally, primarily what we're concerned about with these medications is in the lactation period, they can drive the breast milk. They're good medications. You can definitely use them. Ambien is very widely used, and actually I think there is quite a bit of data on there.
Yeah, I think that's old. I need to update that.
Okay. So there's quite a bit of data on Ambien as well. It depends on kind of what the patient needs specifically. Doxylamine, that was used historically first in diclogis, which was a medication for hyperemesis. And that's a good medication as well. We see that also in the over-the-counter Unisom. Melatonin is recommended a lot of times because, and especially a lot of patients feel very comfortable with it because they perceive it to be a natural type of supplement that they can use, especially for sleep. But we should not forget it's a hormone, and we really don't have a lot of evidence on how it affects other hormonal processes that might be critical in the pregnancy and postpartum period. This is just sort of a note that Unisom does come in 2 different formulations. So it comes in the diphenhydramine formulation and the doxylamine formulation. Either are useful, but you probably want to make sure that your patient is getting the one that you specifically recommend.
And this applies to a lot of OTC meds, which you probably know, but they may say Tylenol PM, and it has different ingredients for the actual active drug.
So stimulants, typically we only would recommend use of stimulants in patients where the benefit clearly outweighs the risk. So the baby can be born with a level of tolerance to stimulants. We consider if we really need to use them, that they're used more on a PRN basis. If the patient is so distracted that they are potentially at risk driving and things like that, maybe that's a good time to use it. Most of the data that we have on stimulants is very, very new, like within the last 5 years. The data that we have currently shows a possible increased risk in miscarriage for patients taking methylphenidate, a possible risk of central nervous system related disorders for all stimulants, a possible risk of preterm delivery for all stimulants, and then there's a more defined risk that we think is probably attributable to the actual stimulants. More certainly is the increased risk for gestational hypertension, but that makes sense because we know that that increases for patients at all times of life. Methylphenidate is probably passed least in breast milk, so if we're thinking about medication during lactation, that's maybe the one to go for.
And I'll give an example of a patient that I took care of who I did prescribe stimulants through pregnancy and lactation. And she was one who her symptoms were so severe that she really could not function without the medication, without being at risk of having an accident, leaving the stove on in the home, things like that. And she told me during her first pregnancy, she was unmedicated and she was drinking 10 to 15 cups of coffee a day and still sleeping 12 plus hours a night because she was so exhausted from trying to function without the stimulant medication. So it seemed to me that prescribing something in a certain dose would be a lot safer than her self-medicating the entire pregnancy with caffeine. So while we do try to avoid these if possible, there are certainly times that it can be indicated. So moving on to lactation, but first I'm going to ask if there's any questions about what we've talked about with the pregnancy medications. Okay, Amber.
How do we join like a registry? Like if we have patients who are on medication, how do we monitor that a little bit better?
Okay, so the question was how would we know, how would we get patients to join a registry? I think we have a link at the end that it's on the Mass General site, the womensmentalhealth.org site. They have, I think, 2 or 3 registries going on right now. So the patients can join themselves. And it's for people who are on medication or are not on medication. So really anyone who's pregnant can join the registry. So you can direct them to that. Now, it's not something that you personally would like receive information about that patient, but it'll help contribute to the knowledge in the field. Kirby?
I was just wondering, I know I didn't see it in there, and it's fine, because I'm not sure. But I was just wondering if there was any information that
Oh,
Yeah,
Buspar.
that's a
Okay,
good
so the
one.
question about Buspar, thank you. Do you know more about that one?
There is limited data. I don't think there's any data that has shown any particular increased risk for anything, but there's not a lot right now. I think with Buspar, that fell into one of the categories that was talked about with possible increased risk for gestational hypertension, but actually that also occurred for some of the SNRIs too. So I don't think it was anything substantial though, but we'll double check that though, because that's my trazodone is an
Thank you.
option.
Yes, good question.
What?
I don't know why we don't have that on our slide. Okay, trazodone, typically considered safe to
Yes.
use during pregnancy.
It's a good option. Yep.
Mhm. Yes, Ivy. That is a good question too, yeah.
I don't think we have any data about immediate versus
Oh,
extended
let me
release.
repeat the question. So
Oh,
it's about
sorry.
stimulants, immediate release versus sustained release.
Yeah, I don't think we have any data about that. I think, in fact, most of the research is just comparing regular Ritalin, like methylphenidate immediate release, and Adderall or amphetamine immediate release kind of formulations. But yeah, I don't think there's any information specifically on.
Yeah, I mean,
especially
even
some of the newer agents.
Yeah, even the extended release doesn't last a super long time. I mean, it might be 8 to 10 hours. So my guess would be that there's not a huge difference there, but I don't know of any specific research differentiating them. All right, so moving on to lactation. So it's important to keep in mind that whether a medication is safe to use during lactation really is not related to whether it's safe to use during pregnancy. So example of that is ibuprofen, and not safe to use during pregnancy, but is safe to use during lactation. So obviously the same applies to psychotropic medications as well. So please don't make any assumptions about what medications may be okay or not okay to use. Make sure you look everything up. And there's multiple hotlines out there that we have in the resources sections as well. There's an app called LactMed that's free that provides all the up-to-date information about a medication's use during lactation, not just psychotropics, but any kind. So just look everything up and get guidance as needed. Don't just assume that they can't take it because they're lactating. Many medications are safe to use. typically, if the patient was on the medication during pregnancy, then it's okay to use it during lactation as well. That applies to most meds. And as I mentioned before, even lithium can be used with caution during lactation. So what affects how a medication is passed in breast milk is related to the molecule size and the fat solubility. So that varies based on the individual medication, of course. And again, a reason why we need to look up everything individually. We also need to consider whether the maternal symptoms or needs may affect lactation or the breastfeeding relationship. So for example, if the parent is depressed, then there might be a negative impact on the breastfeeding relationship. So that would lead us to want to treat in that case. And also considering the age of the child. So a lot of times when we're thinking about these things, we're thinking infants, but it could be someone who's breastfeeding a 1-year-old or a 2-year-old or a 3-year-old, and those children are going to be getting a lot less breast milk, and it's not their only source of nutrition. So I really wouldn't worry much at all about it in an older child. They're going to be getting such a small amount of the medication. It's probably not anything to be concerned about.
Okay, so when we're, oh, no, let's do
one more. Okay, so again, there are many other professionals who may be poorly informed about medications during both pregnancy and lactation. So I hear a lot of people say, oh, I'm not going to highlight any specific types of providers, but my provider said I had to stop my medication as soon as they found out that I was pregnant, or they said I can't take this while I'm breastfeeding. And I'm like, that's interesting, because I know that medication is fairly safe to use during those times. So we don't have to trust what we hear from all other professionals. They may not have accurate information. I also want to mention that I really do think that as psychiatric providers, it's our duty and responsibility to educate ourselves about this population. So you'll also hear people say, well, I don't treat that. I'm just going to refer them back to the OB or the midwife. And I think that that's really unacceptable, because, for example, we wouldn't have the OB or midwife refer to us if it was a patient with mental illness and we would be treating their pregnancy. That wouldn't make any sense. So we have to educate ourselves, and that's part of our ethical responsibility as psychiatric providers. I know not everyone here is a psychiatric provider, but that's applying to my fellow psych NPs. So to back to lactation again, you may want to involve an IBCLC, especially important if there's some difficulty with lactation or breastfeeding. They can help support that relationship.
So treating with medications in the postpartum period, we definitely typically want to treat quite quickly, especially for more severe illness, with both medications and therapy. So we're not going to necessarily wait to start medications, especially if something is, has a quick onset in postpartum period. We're going to see the patient very frequently, involve family members if possible. That's especially important for that collateral information that might be necessary to differentiate somebody who's presenting with what seems to be a unipolar depression, and trying to understand whether or not that could be actually a bipolar depression presentation. Anecdotally, responses to antidepressants might actually be quicker than for other periods of time. So antidepressant treatment in the postpartum period might actually result in quicker outcomes. Again, considering the lactation status and the ease of dosing. Obviously, this is not maybe the most optimal time to prescribe a medication that needs to be dosed 6 times a day or things of that nature, because the patient is already juggling a new baby. So sleep is paramount. So one of the things that I know that Lyons and I both talk with clients about is protected sleep. Patients decompensate very quickly if sleep is severely disrupted. That's especially true for patients with bipolar disorders, but it's true across all psychiatric illnesses. Protected sleep is often very difficult for patients to get. It's made easier if the patient has a partner that can help with cares of the infant overnight. Protected sleep, the recommendation is that the patient will get at least 6 hours of protected sleep. That seems really excessive as far as what I am hearing from my clients. So really, as much as they can between them and the partner, sort of dividing shifts. So we recommend, like, let's just say they are going to get that 6 hours, then both partners would spend a total of 12 hours in bed sleeping. And then one partner would take the first shift, one partner would take the second shift. For patients who are lactating, oftentimes 6 hours or even 4 is much too long and uncomfortable to go between pumping or breastfeeding. And so that just has to work with whatever the patient can do. But if they're still going to pump or breastfeed during that time, then the other partner should take care of everything else surrounding that. So bringing the baby to the bedside, changing the baby, that kind of thing, so that even if the patient has to wake up in order to perform those cares, they can still sort of keep resting and things like that.
And this is one of the times that we would recommend using a benzo, even though we are both we don't use a lot of benzos in our practice in any patients, but in these cases, to help them get some sleep, I do think it's indicated, and I would recommend it.
When we see a patient with a postpartum depression or anxiety with sleep disturbance who is lactating, the first line choice, assuming they had no other previous medication trials, or failures, would be Zoloft and Ativan PRN. Ativan for the benzos is probably the most optimal choice because it's a shorter acting medication that does not have active metabolites, so less likely to have sedation issues in the infant. Monitoring very closely for mania, hypomania, again, remembering that a lot of the clients that we see with depression are actually misdiagnosed. Also assessing for intrusive thoughts, psychosis, and thoughts of harm to self or others. Again, thoroughly for bipolar, just assess for bipolar.
For people who are not psychiatric providers, there are some soft signs that we consider with bipolar that aren't part of the diagnostic criteria, but they can show a higher association with someone actually developing. So a few of those would include a family history of bipolar, poor response to antidepressants, early onset of depression, premenstrual symptoms. Those are a couple that are coming to mind right off the bat. To go back to your question about trazodone, I probably would stay away from trazodone in a postpartum patient if you're starting a new medication, because it may be too sedating for them to be able to take care of the baby. That's why we like Ativan, because usually they can kind of still be alert enough to do what they need to do, but are able to rest and get sleep. If they've been on trazodone for years and they know how they respond to it, it may be okay, but I probably wouldn't start it out new in someone who's postpartum.
I think at the very least, for the sleeping agents, assessing what it exactly is going to look like for that parent and what kinds of cares they need to perform overnight. I currently have a patient whose husband literally just does the cares overnight so that she can sleep. She has bipolar disorder, and that works out really well for them. So we're not quite as worried about sedating her overnight because she gets to do that. So
right, that's a good point. And we see a lot of recommendations from reproductive psychiatrists to really encourage patients to consider using formula and not exclusively breastfeeding when they have a history of bipolar in particular. I'd say I'm not sure how I feel about that, but that is a recommendation that I see frequently because it will allow them to sleep for longer periods of time at night. And I don't think that anyone should feel guilty or bad about their choices, and that may be the right choice for some people. Mm-hmm. Screening tools, you're probably somewhat familiar with these, especially those of you that are nurse midwives. So the Edinburgh is a depression scale that's typically given at about 6 weeks postpartum. There's a new tool, the Postpartum Specific Anxiety Scale. I haven't seen a whole lot about that, but it's out there. There's an app that does the Edinburgh, and I should put that on here. I can't remember what it is, but it's an app that they can complete the Edinburgh on. In terms of bipolar screening, there's a tool that I really like called the Primary Care Mood Check, which is from a website called psycheducation.org, and it goes into some of those bipolar soft signs, and it can be administered to people that have a high literacy level. It does have a lot of words. It's not for someone who has a low literacy level, or I don't think it'll be as effective for them, but that's an option to administer to them. And you may also see the PHQ or GAD, which are kind of commonly used depression and anxiety screening tools.
So I don't know if this is the one that you were thinking of, but there's one called PPD Act, which is actually a new app that also enrolls the person who's completing it into one of the research studies that's currently ongoing worldwide to identify kind of more information about patients in this period. So I'm in this study, and you sign up on the app, and then they send you a collection kit for saliva. So you send that off, and I guess they're looking at genetic factors that may be involved in postpartum depression. Mm-hmm. But I do think there's an app that
I think it includes the Edinburgh, but I can't remember
This one
what it is.
supposedly
That one does too.
Yeah. And it will tell you if you need to sort of seek more care, kind of thing.
So there are some inpatient options where parent can go with the baby and both be hospitalized together. There's not a whole lot of those, but there's one at UNC, so that could possibly be an option for our patients here if they have the resources to do that. And there's some in other parts of the country as well. And then there's also several places that have intensive outpatient and partial hospitalization programs for the postpartum period. And usually they can bring their babies to those as well. So something just to keep in mind as resources. Where are we? Okay. All right. So I just wanted to touch quickly on preconception planning, because you may have patients coming in and saying, I'm thinking about getting pregnant, or I want to get pregnant. What should I do about my medications? So a lot of this is going to be pretty similar to what you would think about just during pregnancy when you're prescribing. But of course, when do they want to get pregnant would be important. So I've heard of people coming in and saying, I'm planning on starting next week. And you're like, okay, well, maybe if we had a little more time, that would be good. But so find out that, of course, what's the condition that they have? Are they currently on medication, and are they working? How long have they been on the medication? What have they tried in the past? And then what they're currently on, how much research is available on those medications during pregnancy. If they're on something that doesn't have a lot of evidence, are there some other medications that you could trial if you have time? If they're saying, I'm thinking of in the next year, then you may have some time to kind of tweak their medications and see if they could become stable on something that has more evidence. Are they on multiple meds right now? If so, could we try to reduce that down and maybe taper off one or two of the medications to see if they can be stabilized? Could they be trialed off medication? So if it's someone who maybe has been on an antidepressant for depression for 2 years and they've been stable for the past year, could we try just tapering them off and see how they do? Whereas if it's someone with bipolar, then you know that they're going to need to be on medication, and I wouldn't recommend doing a trial off medication. Although there are some people with bipolar who are stable during pregnancy without medication. That can happen. And then looking at whether they want to breastfeed again, of course. All right. Any questions so far? We'll have, we're going to cover some resources, and then we're going to do a little bit of discussion and Q&A. And if we have time, we'll do some case studies towards the end. But any questions? Yep.
Is there any, have you come across any data suggesting, I have a lot of moms that have experience that are doing really well during the pregnancy and sometimes do really well at other times during their lives, but they can have postpartum depression for a period of time. So, like, I have someone who's currently on Prozac, I happen to increase 15, she's done really well on 10 for so long, and so she's near the end of her pregnancy, and she's worried that the depression is going to come back stronger. Is there any indication that I should prophylactically increase it to a whole 20 milligrams?
Okay, let me repeat the question.
Oh, yeah.
Okay, so the question was, is there any evidence that if someone is stable currently on medication that they will potentially get worse on the same dose afterwards, right?
Postpartum period.
Okay, and they have a history of postpartum depression.
Yeah, so the best predictor of postpartum outcomes is how the patient is doing, especially towards the end of pregnancy. So that doesn't say that they're protected from it, but if they're stable during pregnancy, that's going to be the biggest predictor of how they're going to do in the postpartum period. I would say that probably not increasing the medication prophylactically, only because with the fluid volume changes and all the hormonal changes, she might actually go back to needing the lower dose, which I've had happen several times with some of my clients. Within that first 2-week, 4-week window after in the postpartum period, sometimes it seems like then we are too much medication for that patient. So, but just being monitoring very closely, and if they develop symptoms, then, obviously responding quicker.
I try to educate patients for probably the last 3-4 months of pregnancy several times, educating them about what they want to look for, what they need to be doing for themselves during the postpartum period, extra self-care, things like that, just to start to normalize some of the symptoms that can occur. and then try to see them frequently afterwards. That can be definitely challenging with an infant.
Yeah.
Sometimes I stay in touch with them by phone if they can't get in, and I don't have a whole lot of patients, so I'm not overwhelmed by it, but the maybe in a practice where I was seeing a whole lot more, I might not be able to do that, but that's kind of how I handle it.
My practice right now is to do a 1 month pre-due date check-in with the patient and her chosen partner, if they have one. And we really review like pretty thoroughly what exactly the signs and symptoms are and when they need to sort of reach out to me. And we'll go over the fact that you don't have to be suffering for 2 weeks. Like if things seem off or weird or not normal, call me within the first, whenever that shows up, and we'll do whatever we can right away to mitigate that.
Yep. Oh, that's a good question, Kirby. So the question was about tricyclic antidepressants. I think do you know a little bit more about that? I think they are considered fairly safe. Is that correct?
So there's actually, I don't think a ton of data. There's more data than there are on tricyclics than there are on like some of our newer antidepressant medications, but most of the data that we have is on SSRIs and SNRIs. But I don't think that there was any, not that I remember at least. I don't really use tricyclics all that often, so I don't think I've looked into that very thoroughly.
Yeah,
but
we'll have to look at it.
But yeah, I think that the data wasn't like outrageous as far as there wasn't anything specifically to worry about, but I would have to double check on that.
There's a question from
Sue?
Okay, good. Sorry, I didn't know if you're talking to someone in the room. So we have a question from the remote site. Do benzos have risks for effects like FAS, since both benzos and alcohol affect GABA?
Yeah, I don't know of established risk that we've come across. That's a really good question, though, and a good point. I guess theoretically there could be, but I don't think that's been established in the research.
Yeah, I would agree with that. So some resources that we promised, there are quite a few resources out there. The women's mental health we mentioned is one that is a really great synthesis of literature as it comes out. And they do have an email digest, so you can sign up for their emails. And I think they come out every 2 weeks or so, and they'll talk about any research that's been published. Mother to Baby is also another good one. There are state-specific representatives, so you can call them and they'll send you whatever information they have on using that medication during pregnancy. Infant risk is one related to lactation, and mother risk is another one. I'm not sure of the differences between all of these, but they all seem to be pretty high quality, and they have phone hotlines usually and information on their websites. And then reprotox.org is another one. Postpartum Support International, their website, postpartum.net, has a lot of resources for patients and families and phone support groups. They have a reproductive psych listserv for professionals who join. So we're both on that. We see a lot of really good information come through that. There's a small number of people who are trained as reproductive psychiatrists in the US, and I guess some in other countries as well. And most of them are on this listserv. So it's like names that you'll see around in journals a lot and stuff. So that's a really good resource. The LactMed app I mentioned, Mommy Meds is another one that has an app that's geared towards patients. So we'd like to hear from you all. How have your opinions changed during this presentation, and how do you think your practice will change? And then we'll also take other questions as well. Also, here's your sign-in sheet. Reminder again, if you didn't sign in yet, make sure you sign in on that, that URL so I can get your email, and then I'm going to send you the information about the CEs and also the slides. Sue, are there any other questions from the online audience?
So if you all could just type into the chat window if you have additional questions, that would be great. Thank you.
And does anybody in here have any, like, I don't know, takeaway points or feedback they want to share about like how your opinions might have changed, or any questions? Or yes.
Mentioned that the that's the one that I found super helpful because you can contact your state representative.
Mother to baby, yeah.
Mother to baby.
Yeah.
Mhm.
You can contact your state representative and give them a list of the meds your patient's on, and they'll compile a report for you of the research that's related to the medication, and either email it or mail it to you. And you can't, one of the caveats is you can't give that to the patient, but you can use it to either decisions inform, and I just found it super helpful. And then they'll like follow up with phone calls and talk to you about the research you might understand, and they're really awesome. It's free.
Yeah, so that was a recommendation for the mother to baby site, which will provide individualized information about the medications that the patient's on and provide follow-up and support on understanding the research.
And specifically, Lauren said that you can actually send a list of the medications that your patient is specifically taking, and they will send back the research that's available on those medications for you as the provider to use, not for the patient.
We have quite a few questions when you're ready.
Oh, great. Okay, go ahead.
Okay, go ahead.
Just to clarify, Latuda isn't any worse. It just isn't any better.
It's that we don't have information on it, so we
Right.
don't know.
There's not evidence to suggest that Latuda has poorer outcomes than any of the other SGAs. There's just no evidence, period.
The next one, have you had any patients on long-acting injectables?
That's a good question too. I personally have not. That question has come up on the reproductive psych listserv. I don't think that there's any research on it. We don't think that it's any worse than them being on a PO version of the same medications. And typically someone who's on a long-acting is really in need of it for psychiatric stability. So probably the benefits are going to outweigh the risks.
I have a comment and a few more questions. I have a comment that says, I'm definitely more comfortable with prescribing in the perinatal period. Thank you to our presenters.
Yay, you're welcome.
I have another question. Would you please repeat the second generation antipsychotics in order of safety?
So it wasn't an order of safety. It was an order of how much research we have on the individual medication. So I believe it's Seroquel, Abilify, those two for sure, Risperdal, Zyprexa, and Geodon. Yes. I think those are the ones that we have the most data on as far as the second generation antipsychotics, with Seroquel being the most and Abilify being the second most data, followed very closely by the rest of those.
Okay, next question is, we have a PMHNP in women's health doing integrated behavioral health care, evaluating any OB patient with a mental health concern. The use of Ativan for sleep was new to me.
Okay, so we were talking about that during postpartum. That is one that we would recommend, not for long-term use, but for short-term use to stabilize the patient.
I think in a lot of cases that would be a really good option for somebody who's not sleeping due to anxiety. So if their mind is racing, if they're having a lot of intrusive thoughts and things like that, the Ativan can be very good to help with the anxiety and thus subsequently help with sleep, but it's also a bit sedating in and of itself. So.
Next question, does anyone in practice use an informed medication consent document for patient to sign, or just in your notes, risk versus benefits?
This question comes up, I think, every time we present on this.
Yeah. So no, neither of us do.
Yes, we do not.
But every time we get this question, at least I question whether I should be using it. So I don't think it's a bad idea. I mean, I know that some people don't feel like it's necessary, and I don't obviously feel like it's that necessary or I'd be doing it. But certainly, we're sort of in a litigation society, so protecting yourself if you feel like that's necessary, I don't think is a bad idea.
I'm kind of opposed to it, actually, because I don't think that we should treat pregnant people any differently than we treat anyone else. So if we don't do it with other patients, then why would we do it with pregnant patients? And I think it might provide a false sense of security as well, because it's definitely not going to protect you against a lawsuit. And if there was something to happen, it's not going to really do anything. I will say that I want to look more into this, but I started sort of briefly looking into how many lawsuits are there actually, and I don't think there are really that many. Like it's sort of like a fear that people have, but it's not a real common thing to get sued for something happening during pregnancy.
I have one more comment and another question from the participants remotely. A comment is, this is just such important information and the presenters did a wonderful job, so thorough, and you both are clearly passionate about this topic.
Thank
Nice.
you.
Thank you.
And then the next question, would you please provide some references for lithium use? As you stated, most people don't want to use it.
Yeah, we have some references at the end of the slides. I'm not sure if they specifically apply to lithium,
I
but
don't think so. A lot of the like references, I guess, for the fact that people are using lithium during this period are more from us having talked to other providers who are doing this, especially part of that reproductive psychiatry listserv. I mean, some of those folks are, I would consider them the most knowledgeable people in the country and across the world on this topic, and are doing this using lithium in their clients. So yeah, I don't know that we have like a specific research article that says, go ahead, you can use this under these circumstances. But, you know, when the benefits outweigh the risk, and especially, oh, I'm sorry guys, sorry about that. When the benefits outweigh the risk, and especially for patients for whom we are trying to prophylactically prevent maybe a postpartum psychosis or things like that, then, you know, a lot of people are definitely using lithium for those reasons. Yeah.
So on Mass General's website now, they do have guidelines.
Oh, perfect.
okay, cool. So,
Awesome.
so we heard from one of our audience members that the Mass General site does have guidelines for using lithium during pregnancy.
The last comment is, very good presentation. It will change my practice. Great presentation. This will improve my practice and I feel more confident treating perinatal patients. And do you always consult with OB when prescribing?
Great.
You always consult with OB. I try as much as I can to involve the OB. I don't think that's very often possible. A lot of times they're very busy and we sort of don't have the opportunity to interact, but I try, but not always, no.
Yeah, it's always best to collaborate if possible,
Yeah.
but it definitely can be a challenge. And sometimes that may involve some education of the other professional as well, which can sometimes be delicate. So, so it's good to do if possible. All right, what about other questions or comments from our audience here? Yep. That's okay.
Have you ever come across experience where you have not on the same page as the OB provider and then try to reach out to them? But I mean, you know, you didn't have a conversation.
Yes.
I think both of us have, yes.
No comment. I'm just gonna say.
I had a very good interaction.
It can be
like this
good, yeah.
recently. I think sometimes it's really just a lot of people, even in psych, are just really uninformed about
Yeah,
this.
yeah.
And the situation that I had recently was an obstetrician who reached out to me because I had prescribed, I think it was Prozac actually, and they were really concerned about it. And when I kind of reviewed some of the data that was on it, it was informative for them, and it worked out really well that we actually got in touch, and then they felt more comfortable letting the patient stay on it. So
That's probably too negative, because more commonly it's just that I don't hear back from them. Like I try to get in touch with them and I can't get a reply. So anyway, but yes.
Can you share the comment with us that you all were just referring to?
I'm sorry if I forgot you. The question was, do we try to collaborate with the OB or provider who's caring for the pregnancy?
And I think the other question was if we've ever experienced an issue with disagreement between ourselves and another provider about what the medication choice should be. Yeah.
Thank you. Yeah.
And do you ever talk to the pharmacist?
Okay. Do we ever talk to a pharmacist?
Because I've seen the patient and the pharmacist that didn't
Right. So the comment was that sometimes the pharmacist says they wouldn't give the medication to the patient. Yeah, I have had that happen.
I don't know if I've actually had that happen or if I've just heard of it, but I haven't actually had an interaction with a pharmacist. But that's another situation where I think maybe just the lack of knowledge, and if you can reach out and provide information and inform the person, then sometimes that can be enough to change somebody's mind. I would argue about the ethical nature of withholding medication that's been prescribed, and maybe looking into that a little bit, but yeah.
You're going with the pharmaceutical company's recommendation. It's not advised.
Right. Right. Right.
Right.
Right. So the comment was that sometimes they're covering themselves because the pharmaceutical company recommends not advised. Yeah, I would definitely reach out to a pharmacist because they are able to provide information that's within their scope, but they shouldn't really be making treatment recommendations. Amber?
So I have success finding literature that supports my decision making and sending it to the pharmacist and the OBGYN. And usually I get a call back that's like, okay, I've reviewed what you sent. It's okay if we monitor the patient on this medication. At work, I also have a list of OBGYNs who I'm really easy to work with. They're very pro keeping people on medication if that's their choice. And when they tell me that they're looking at pregnant, I'll say, do you have an OBGYN? And they say no. I'm like, here you go.
Yeah, or midwife. Yeah. So the comment was that that she has a list of OBGYNs or other providers who she's found are supportive of people staying on medication, and also that she sends them literature supporting the medication decisions, and that has been successful as well. Ivy, did you have a question?
Yeah, it was a comment actually, and I'm sure it's required here, but I've heard anecdotes of a lot of people who've been told by their OBGYNs or other medical professionals, just really minimizing the importance of breastfeeding, and just saying like, oh, we should just stop breastfeeding. They're basically too lazy to look into a specific medication. So, and I know, like, I'm certain that we all understand how important breastfeeding is, not just to the baby, but to the women. So I just kind of want to hammering that we always support lactation. Because that's so often minimized how important it is to get through to the fire end. I just wanted to throw that out.
Yeah. So So the comment is that other providers may just tell people not to bother breastfeeding anymore and just to give it up because they haven't had time to look into the medication that they're prescribing, and that it's important to support and validate the person's choice to breastfeed or lactate as they want to.
And equally important, I think, to support their decision not to. I actually think that more recently, maybe this is an indication of a cultural shift, which would be good, but more recently I've had moms feel the opposite, like they didn't want to lactate or breastfeed and they felt kind of shamed in that decision. So
that can definitely happen too.
Maybe a positive sign that we're shifting. I don't know, maybe.
There's a lot of controversy about that topic out there, definitely.
We have one more comment from the remote site. She says that I think it's worth mentioning that bed sharing should be a consideration when a parent is taking medications with the potential for sedation.
So should be a concern, maybe? It was that, I'm not sure if a consideration.
A consideration,
So yes, you should ask patients if they are bed sharing, and that would definitely be something to be very cautious with. If they were taking sedating medications, it would not be recommended for them to bed share. It depends on, I think, the parent. Some sleep better with the baby in the room with them, and others do not. So it really should be individualized. But if they can sleep on a separate surface in the same room, that's the recommendation that we're getting now from pediatrics, I guess, right? Some of y'all may know better than I do.
Yeah, but that's a good point, though, because even though that's the recommendation, there are still some people who, for their own personal reasons, choose to bed share. So
yes,
asking about that and making sure that we're assessing for it is important for sure.
Definitely. All right. If everyone's not too tired, we can run over a couple of quick case studies and talk about some of the these real world situations. So this is a patient that has a history of bipolar 2, and she came in for her med follow-up appointment with her psychiatric provider and informed the provider that her IUD had fallen out, and she went to get a new one put in, and she found out that she was pregnant. So she was using birth control, but it didn't work in the way that it was supposed to. So currently about 3 weeks pregnant, and her current medications are Lamictal, lithium, and lorazepam. This patient was very difficult to stabilize in terms of her bipolar symptoms, so she was on quite a few medications at this time. So, so what are some thoughts about what you might do in this situation? Okay. So find out if she wants to keep the pregnancy. That's very important. Yeah. First step.
Let's assume she does.
Assume she does.
For the case study.
mood is right now, is she's stable right now on the med.
Okay, so
Yep.
first assess her current mood and current functioning and stability.
Any thoughts on medications in particular, or what you all might do as far as this list goes?
So maybe tapering one of the mood stabilizers was an option. Probably lithium and Latuda would be the ones that we would want to attempt to remove first if possible. Okay. Any other thoughts about this one?
So we have a comment from the audience and online. We have a reduced lithium until day 55 D/T cardiac anomaly or D/C lithium if possible. And then someone said agree taper lithium and increase visit frequency.
Yep.
I think it's a really good option.
Definitely.
She's right in that, you've caught her right at that sweet spot where she's 3 weeks. So like right around that time where cardiac formation starts to occur, if we could potentially get that lithium away for the period of time where the cardiac formation is happening without destabilizing the patient, that would be nice.
And I know we talked a lot about Latuda. If someone was already on Latuda, it is similar to the other second generations. It's probably okay. We just don't really have the data right now, but I wouldn't like switch her to something else just for that reason.
Yeah. Especially because with Latuda not having data, we don't really know if there is malformation risk. So switching the patient off of something that we just don't have evidence for would be sort of unadvisable, especially with Lyons's comment that she had been difficult to stabilize. Plus, there's already been exposure at 3-week mark. So even though there's a lot of organ formation still occurring up until the end of the first trimester, there's already been exposure to it. So
the other thing I would do is refer to high risk OB right away. Is there another comment, Sue?
Yes, with that number of meds, it makes me think she might have severe symptoms. Maybe lithium is indicated.
Yeah. Yes. That's very possible. Definitely.
And then to follow up, how fast would you taper lithium?
I guess if I was doing that first, I'd probably just do 300 milligrams at a time. What do y'all think? Agree?
I mean, obviously, if we're choosing to do this taper, like somebody said, just really increasing the monitoring, having this patient come in more frequently and that kind of stuff, that would be a hard choice. I don't know if I would choose to actually pull it off. If somebody had been really difficult to stabilize and we're weighing the absolute risk of that Epstein's anomaly.
So I think actually if I were starting to taper lithium, it would be so slow that I wouldn't miss the cardiac formation window anyway. So I might just do the Latuda first before I did the other ones. That's a tough situation.
This is a really good case study example of just how individualized each case is. Like there's never going to be one right answer, right? There's always going to be you and the patient together determining what each of you feels most comfortable with based on the evidence that we have to support these decisions, which in a lot of cases isn't a lot of evidence. So when we look at a complicated case like this, it wouldn't be wrong to keep the patient on all these medications. It also wouldn't be wrong to try to work on bringing some of them down.
And that brings up another good point of always taking into consideration what the person prefers and giving them as much information as possible. I actually tend to, I have to remind myself of this because I'm so comfortable prescribing medications during pregnancy and I'm very comfortable taking medications during pregnancy that sometimes I'm like, it's okay to take it, it's fine, it's no problem. And I forget to like hear what the patient feels about it and they may not be comfortable taking it even though it has all this safety data. So getting that first is also a key component. Okay, so here's a patient who's 26 and she's interested in becoming pregnant in the next 1 to 2 years. So we have a little window of time here, so that's great. And she has a bipolar disorder, generalized anxiety disorder, and obsessive compulsive personality disorder. She's currently stable on Lamictal, Vibrid, and she takes Zofran. She has nausea related to anxiety, and she also takes N-acetylcysteine. I don't know if some of the non-psych people here may not be familiar with that. It's Mucomyst, and it also has some psychiatric indications for OCD and anxiety disorders. These are the meds she's been on in the past. So she's already tried Prozac, clomipramine, and Zoloft, and she tried tapering off of the Vibrate at one point and did not do well psychiatrically when she tapered off. So what do you think you would advise her to do, or what would you want to try in terms of her medications? Leave it alone. Okay, we have several people saying that. Yeah.
So
yeah.
NAC is used really highly in a lot of medical fields, including OB, for exactly what Amber said. So what the audience member said was that N-acetylcysteine, there was evidence that it protects against miscarriage. So I think it's like kind of anti-inflammatory and things of that nature. So yeah, it definitely was used. I don't know if it currently is, but I know that there's, I've read some research where it has been used in the past to support pregnancy. So
the Vibrate is a new drug, so we don't have a lot of data there. It is pharmacologically similar to trazodone, so we can kind of extrapolate that it might be okay during pregnancy. Did you have a comment also?
Yeah, so this is somebody that's really thinking hard.
That's right. Yes.
Okay, and, you know, that little OCD there.
Yeah.
And so probably the biggest thing you're going to have to do is sort of convince her that it's okay to stay on the
Sure. Yeah. Could be. Yeah.
Go through the whole, you know, like this
Yeah.
is the real risk here and everything. But she also knows what she felt like before.
Yeah. Yeah. Yeah.
You're going to have to convince her.
So the comment was because she has some obsessive compulsive traits and anxiety, she may be more worried about taking medication, may have to really work with her to help her understand that it can be safe to do. Did you have a comment too, Amber?
I was going to say that I actually had a situation similar to this with Vibrate, and I talked to a specialist with supporters, and he actually will say, like, that's like one job is to look at medication to make sure that it's safe during pregnancy. And he said that he had no concern. I feel like his name is like
Okay.
he's Santa.
Oh,
Okay,
do y'all
great.
know? Okay, so there was a comment that that she talked to someone who specializes in medications during pregnancy, and they did not have a concern about Vibrate. Okay.
But again, I think it's one of the things that Lyons said is that, you know, we can sort of extrapolate some information, but I do think we need to be careful of the extrapolations that we make.
True. Yes.
Because as we can see in a lot of other cases, there are situations where very similar medications can have very different pregnancy and neonatal outcomes. So, you know, extrapolating to a certain degree might be helpful, but, you know, remembering that we ideally would like to base our information and our decisions on the literature, even if that is a decision that we are going to say we don't have the evidence, so we're just going to go with what's best for the patient at this point. So.
Okay, so here's a 36-year-old woman presenting at 3 weeks postpartum. She's not breastfeeding. Her symptoms are severe anxiety and insomnia, agitation, dysphoria. She was admitted to the hospital psychiatrically overnight for suicidal ideation. She's not having any psychosis or intrusive thoughts. She's only sleeping a couple hours per 24-hour period because she's so agitated and anxious. Her current medications that she's on are Savella for fibromyalgia. For the non-psych people, this is, or you may know this, I don't know, but it's an SNRI antidepressant. So it actually is a psychiatric medication, although it was never used for depression. And she had tried a lot of other meds in the past for her fibromyalgia and had not been successful. And she'd been taking Ambien 10 milligrams for many, many, many years for her chronic insomnia. So what do you think, and when you see this case, what do you want to be thinking about? Ruling out bipolar, definitely. Go ahead, Sue.
Okay, double check that she's not having intrusive thoughts and is ashamed of them.
Okay, good. So assessing for intrusive thoughts. Thank you. What would you think for medication for this patient? So maybe a second generation antipsychotic, okay. Seroquel could be an option.
I think Seroquel is a good example of a medication that can hit multiple symptom clusters for this patient. So
I would be cautious if it's extremely sedating for the person. They need to have backup support to take care of the infant, because there are, you know, as you know, there are some of those patients that are just so sedated from Seroquel that they can barely function, or they sleep for 12 plus hours.
Still in the hospital?
No,
Oh,
she's out of the hospital. She's outpatient now. All right. Let's see.
Do you want to?
Oh,
This is continuing. Oh, okay.
oh gosh. Okay. I forgot about this part. So, so everyone recognized that we should have been thinking bipolar, but unfortunately we were not thinking bipolar at the time. And the patient was started on sertraline, tried a bunch of different benzos. Nothing really helped a whole lot and was very symptomatic, continued to have difficulty bonding. So really would definitely move into the bipolar thought process here and get them off the Zoloft and off the benzos and just onto something to stabilize their mood.
And then instead of doing another case, do you want to ask if there's any last questions before?
Sure, yeah. Any other questions that we, so we don't run out of time before we finish here or online? Okay.
Quiet group.
All right. So this is a 28-year-old patient who came to someone as a transfer. They were diagnosed with PTSD and ADHD, and they were currently on Wellbutrin, Seroquel, Ritalin, or Concerta, and Lexapro. So kind of a lot of medications, but they had been doing well for the first time in many years, and they had had many other med trials, and nothing else had seemed to help them. So it seemed like this was the best combo for them, but they had decided they wanted to get pregnant in a month. So what do you think? What would you try? Okay, so a recommendation to try getting them off Ritalin.
Mm-hmm.
That makes sense.
Good option.
Mm-hmm.
Find out the need for
Okay, yeah. So was the Seroquel just for sleep, or was it really for a mood stabilizer? They're not diagnosed with bipolar, so kind of question whether they actually need that medication. Those might be the first two places that you could go if you only have a month, but also keep in mind that it could take them a while to get pregnant, so they might not be pregnant in a month.
Any thoughts from online, Sue?
Yeah, so keep it all, but maybe see how needed the Ritalin is.
Mm-hmm.
And the next one is in they are stable for the first time, maybe enjoying stability for a while longer before pregnancy if patient is open to it.
That would be an idea.
Yeah, no, I think it's a good thought about the Ritalin. That's really the main concern that I have with this group of medications.
Mm-hmm. Yeah.
And assessing really how severe the ADHD is. Maybe the Wellbutrin can take care of enough of it to get the patient by without their stimulant medication.
Mm-hmm. Okay, so here is a patient who's 8 months postpartum. She is still breastfeeding. Her symptoms are anxiety, irritability, poor sleep, worrying, and ruminating. She does have a history of previous similar symptoms, some depression, substance abuse, and trauma history. And she's diagnosed with generalized anxiety disorder. Started on Celexa because I think that was something that had helped her in the past, and titrated up, but in about 4 months became hypomanic, sleeping only a couple hours a night, impulsive, irritable, agitated. So then it was changed her diagnosis to bipolar 2, and she's still breastfeeding. What would you want to be thinking about medication-wise for her? Maybe a second-generation antipsychotic. Okay, that's a good option.
Did you say lamotrigine? That's a good option too.
Lamotrigine could
Just
be.
with the education piece about potential
Mm-hmm.
risk in the infant for
Mhm.
SJS.
Mm-hmm. How about lithium? Since she's hypomanic. Certainly an option to consider, I would say. Kathy's saying, no. You like the second generation better? Fair
Yeah.
enough. Yeah. But don't forget her baby's 8 months old, so they're not a brand new, but yes, still a consideration. But again, thinking about they're 8 months old, so they're not getting probably as much, although at 8 months, it's maybe questionable. I mean, they may still be getting quite a bit, but you could probably be a little more flexible with your medication choices, and maybe look at lithium. Yep.
Yeah, Sue?
Lamictal titrated up until symptoms are controlled.
Okay.
Mhm. Good option.
Okay, I think this might be our last one. So this is an 8 months pregnant woman who's 29 years old, and she's previously been diagnosed with bipolar 2, PTSD, and cluster B traits. And her symptoms currently are extreme irritability, hypervigilance, nightmares, poor sleep, dysphoria, increased energy and goal-directed behavior. And she's a single parent. She will have minimal support with taking care of the infant. She would like to try to breastfeed if she can. She's not on any medications right now. Okay, possibly lithium, because she is 8 months pregnant, so she's past the fetal cardiac formation. Could be an option, definitely. Any other ideas?
I have therapy in all caps.
Okay, certainly we recommend therapy, yes. You also have to think about a single parent with poor support. It's maybe difficult for her to access those resources. A lot of people, if she loses her Medicaid after she has the baby, she may not have insurance. But yes, we always recommend therapy if at all possible.
Any other, no, Sue muted again, never mind. So I think one of the things that, maybe to assess for is, has she ever had another child? I don't know. So assuming that she's had previous pregnancies, what did the last postpartum period look like?
That's a good one.
Does she have any history of postpartum psychosis or any really concerning postpartum symptoms? That would be a case where maybe we would think more highly about lithium in this person instead of just looking at general stabilization of her mood.
I think Seroquel or Zyprexa could be a good choice as well for this patient. And that may target some of the PTSD symptoms that she's having. So if we could find one thing that could target multiple symptom clusters, that would be good. So we already talked about that. And we talked about our references. I'll email these out to you so you'll have these. It's not all the references in the world, but there's the stuff that we refer to. Thank you all so much for coming. We really appreciate it. Thank you. Thanks to all our online participants as well. That was great to have you there.
We had a lot of online participants. It was awesome.
Yes, and we did record the talk, and we'll try to post it somewhere. Thank you.
So if there's any last things from any of the online folks, we'll stand around for a second. They can ask us if they need to.
Thank you. Actually, I'll turn our mic off so we're not screaming in their ears. All right.
Good to see everybody.
Yeah.
That was Goat Kato.